Daniyal will just start in a couple of minutes. We're just waiting for people to join.
Assalamu alaikum, sir. Okay.
Please mute your other devices. You have an echo, Dr. Daniyal.
जी सर, अब सही है? Is it okay?
There's still a little echo. I think you need to mute one of the devices that you have.
Hello.
जी Daniyal, it's okay. It's okay now.
ठीक है सर, सही है. ओके सर, ओके. सही है, सही.
So, Daniyal, I'll do an introduction and then you can start. I welcome you all to yet another sessions of the Resident Corner module. These sessions are arranged by Department of Neurosurgery at Liaquat National Hospital. The idea behind these sessions is to develop 3D neuroanatomy, which is very important. The topic of our presentation today is CP angle anatomy and relationships. And the presenter is Dr. Daniyal. Dr. Daniyal is AF4 resident at Liaquat National Hospital. The expert panelist today is Dr. Mohammad Hassan. Dr. Hassan is assistant professor at Pakistan Institute of Neurosciences. Dr. Hassan, I welcome you to this session. Dr. Hassan, can you hear me? I think he has some problem with his audio. So Dr. Daniyal, can you please start your presentation? And I urge you to ask questions and participate in these sessions because these sessions are for you. Dr. Daniyal, please start your presentation.
Okay, sir. Hello. Today's topic of presentation is Cerebello-Pontine angle anatomy and its relations. This Cerebello-Pontine angle is located between the superior and inferior limbs of the angular cerebello-pontine fissure. The cerebello-pontine fissure is formed by the petrosal cerebellar surface which folds around the pons and the middle cerebellar peduncle. The cerebello-pontine fissure opens medially. It has two limbs, the superior limb and an inferior limb that meet at an apex laterally. The 4th through 11th cranial nerves are located near or within the angular space between the two limbs that are commonly referred to as CP angle. The 4th and 5th, that are the trochlear and trigeminal nerves, are located near the superior limb of the cerebello-pontine fissure, and the glossopharyngeal, vagus, and accessory nerves are located near the inferior limb. The 6th nerve, which is the abducens nerve, is located near the base of the fissure. This is a diagram of the petrosal surface of the cerebello-pontine angle. In this diagram, we can see this is the cerebello-pontine fissure. It has two limbs. This one is the upper limb and this one is the lower limb. It meets at an apex laterally. This is the apex, and from here continues the petrosal fissure. This petrosal fissure divides the petrosal surface of cerebellum into an upper part, superior part, and an inferior part. As we have already studied in previous lecture, that the upper surface part of the petrosal surface is then divided into quadrangular lobule, simple lobule, and superior semilunar lobule, and the lower part is divided into inferior semilunar lobule and biventral lobule. This is another diagram showing the structures at the CP angle. This is the midbrain. Below is the pons. Below the pons is the medulla with pyramids and the olive. Between the pons and the medulla is the Ponto medullary sulcus, and between the pons and midbrain is the Ponto mesencephalic sulcus. This is an diagram B is an enlarged view. Here we can see again the cerebellopontine fissure, the superior limb and the inferior limb of cerebellopontine fissure. This is a diagrammatic illustration showing the right cerebellopontine angle. The retractor is applied on the petrosal surface of cerebellar hemisphere. This is the retractor. Here we can appreciate some important structures, that is the foramen of Magendie medial to the cerebellar tonsil and the foramen of Luschka, from where arises the choroid plexus. Anterior to that is the 7th and 8th cranial nerve. The 5th cranial nerve arises through the Meckel's cave, that is also known as trigeminal cave. The 7th and 8th, that are the facial and vestibulocochlear nerves, that comes through the internal acoustic meatus. The 9th, 10th, and 11th, that are the glossopharyngeal, vagus, and accessory nerves that enters through the jugular foramen, and the hypoglossal nerve enters through the hypoglossal canal, that is ventral to the olive. Now we will discuss about the division of CP angle. It is divided into 3 neurovascular parts: the upper complex, the middle complex, and the lower complex. The upper complex has one artery, that is the superior cerebellar artery. The one shaded in green is the superior cerebellar artery. It includes the midbrain. It has 3 important nerves, that are the oculomotor, trochlear, and trigeminal nerves. Oculomotor, trochlear, and this one is the trigeminal nerve. It has cerebellomesencephalic fissure. This is the cerebellomesencephalic fissure between the cerebellum and the midbrain, the superior cerebellar peduncle, and it includes the tentorial surface of the cerebellum. The middle complex has anterior inferior cerebellar artery, the one shaded in green. Important structure is pons. There are 3 cranial nerves, that are the abducent nerve. This one is the abducens, and the facial and vestibulocochlear nerves. These are the 7th and 8th cranial nerves. The important structure is middle cerebellar peduncle, and here there is one fissure that is between the cerebellum and pons. This is the cerebellopontine fissure, and it includes the petrosal surface of the cerebellum. This is the petrosal surface. The lower complex includes an important artery that is known as the posterior inferior cerebellar artery, the one shaded in dark green color. It has medulla, 4 important cranial nerves, that are the glossopharyngeal, vagus, accessory, and hypoglossal nerve. The cerebellomedullary fissure between the cerebellum and the medulla, inferior cerebellar peduncle, and it has the suboccipital surface of the cerebellum. So now is specifically discussing about the retrosigmoid exposure in the right cerebellopontine angle. Here we can see the 8th cranial nerve, that is the vestibulocochlear nerve, that enters through the internal acoustic meatus along with the labyrinthine artery, which is a branch of anterior inferior cerebellar artery. We can also see the posterior inferior cerebellar artery that goes around the 9th, 10th, and 11th cranial nerves. Above the 8th cranial nerve is the subarcuate fossa, through which, and that is superior lateral to the 8th cranial nerve, and subarcuate artery enters through this. We can also see above the superior petrosal vein. Now in this diagram, there is a cleavage plane created between the upper and lower bundle. The upper bundle includes the superior vestibular nerve. This one is the superior vestibular nerve, and this one is the inferior vestibular nerve along with cochlear nerve that we will see in next diagram. In this diagram now, there is a cleavage plane created between an inferior vestibular nerve. This one is the inferior vestibular nerve, and this one is the cochlear nerve. The cochlear nerve lies anterior to the inferior vestibular nerve. This is the superior vestibular nerve. This one is the nervus intermedius that goes laterally and it joins that goes distally and it joins the 7th nerve, that is the facial nerve. In this diagram, the superior vestibular nerve and the inferior vestibular nerve have been divided, and we can appreciate the cochlear nerve that is anterior to the inferior vestibular nerve, and the facial nerve which is anterior to the superior vestibular nerve. This diagram is showing the lateral view, the right trigeminal nerve. In this diagram, the lateral dural wall of the Meckel's cave has been removed. The Meckel's cave is a dural outpouch in the upper part of the petrous bone of the petrous part of the temporal bone. The Meckel's cave comes through the posterior fossa into the middle cranial fossa. Meckel's cave is also known as trigeminal cave or trigeminal cavity. Here sits the ganglion of trigeminal nerve. In this diagram, we can see the anterior or motor root of trigeminal nerve and the posterior or sensory root of the trigeminal nerve along with the ganglion of trigeminal nerve. In this diagram, the dura has been removed and we can see the ganglion along with the divisions of the trigeminal nerve. The first division, second and third division, this is the ganglion of trigeminal nerve, and this is the root of the posterior root of the trigeminal nerve. This is an enlarged view of diffuse anastomosis between the ganglion and the sensory roots. Here in this diagram, we can see anastomosis between the sensory root, this is the sensory root, and motor rootlets of between the through the motor rootlets, the anastomosis between the motor and sensory root. This is the cerebellar lip. In the next diagram, this cerebellar lip obscures the junction of the sensory part of trigeminal nerve with the pons in retrosigmoid approach. These are the divisions. The V1 division is rostromedially, the V3 division is caudolateral, and the V2 division is in intermediate location. In this diagram, there is relationship of trigeminal nerve with the superior cerebellar artery. The dura has been removed in this diagram. These are the divisions of trigeminal nerve. This is the sensory root that goes along below the superior cerebellar artery to form the junction with the brain stem, and it is also intertwined between the superior petrosal vein. In this diagram, we can see the loop of superior cerebellar artery. The superior cerebellar artery comes in contact with the posterior root of trigeminal nerve at the division of superior cerebellar artery. The superior cerebellar artery divides into rostral trunk and the caudal trunk. In this diagram, there is a variation. The superior cerebellar artery divides early into a rostral trunk and the caudal trunk. This one is the rostral trunk, which indents on the superior aspect of the trigeminal nerve, and this one is the caudal trunk of the superior cerebellar artery. This is another enlarged view showing the three divisions of trigeminal nerve along with the superior petrosal vein and both the trunks of superior cerebellar artery, the rostral trunk and the caudal trunk of superior cerebellar artery. Now we will discuss the suprametal variant for in the retrosigmoid approach. Here we can see the cerebellum has been retracted to and this is the left cerebellopontine angle. There is a superior petrosal vein that is blocking access. In the next diagram, this superior petrosal vein has been divided, and now we can see the suprametal tubercle. This suprametal tubercle lies above this part, that is the porus of the internal acoustic meatus through which the 8th and 7th cranial nerves are entering. Above is the suprametal tubercle and it is lateral to the trigeminal nerve. The dura has been removed in this diagram from the suprametal tubercle. In this diagram, the suprametal bone has been removed so that the exposure of the sensory root of trigeminal nerve has improved of about 1 centimeter, and we can also now appreciate the clivus. In this diagram, we can see the posterior part of the Meckel's cave has been removed, and this is the right cerebellopontine angle. Here, this is the internal acoustic meatus through which the cranial nerve 8 is exiting. In this diagram, the suprametal tubercle again has been removed so that the exposure of sensory root of 5th cranial nerve has improved. This diagram is showing the superior view, and in this view, this is the suprametal tubercle. It lies lateral to the trigeminal nerve. This is the trigeminal nerve. It is lateral to trigeminal nerve. This is the superior petrosal vein. It is below the superior petrosal vein, and it is anterior to the facial and vestibulocochlear nerve. So the suprametal tubercle is anterior to 7th and 8th nerve, below the superior petrosal vein, and lateral to 5th cranial nerve, that is the trigeminal nerve in superior view. Again, this is another view, the lateral view. This part, that is the suprametal tubercle, has been removed. This is the trigeminal nerve. This is the suprametal superior petrosal vein. The superior petrosal sinus has been divided to improve the access and view. And behind the suprametal tubercle, there is the 7th and 8th, that is the facial and vestibulocochlear nerves. This is a left retrosigmoid exposure. Here we can see the facial nerve. The facial nerve is slightly below and anterior to the 8th nerve at the junction with the brain stem. In this diagram, the 8th cranial nerve has been elevated along with flocculus also has been elevated to improve the view of 7th cranial nerve. This diagram is showing choroid plexus. This is the choroid plexus that is protruding through the foramen of Luschka. Anterior to the choroid plexus is the flocculus. A rhomboid lip. In the next diagram, this is an enlarged view. Rhomboid lip is actually a neural pouch that is on the anterior aspect of the lateral recess. So a nerve hook has been placed in the rhomboid lip. This is the choroid plexus that is protruding through the foramen of Luschka. In this diagram, this is the left cerebellopontine angle. There we can see the eighth cranial nerve, that is the vestibulocochlear nerve, the loop of Ica that is present between the eighth and anterior to the eighth is the facial nerve. It is between the seventh and eighth nerve. And also there is a dural septum between the glossopharyngeal and vagus nerves. This is the cleavage plane is created, the eighth and nerve is elevated. Here we can see that the loop of anterior inferior cerebellar artery is present between the seventh and the eighth nerve. Now, the posterior wall of internal acoustic meatus has been removed. We can see the dura, the superior vestibular nerve, and the inferior vestibular nerve that is entering through the internal acoustic meatus. Below is the glossopharyngeal and vagus nerve that enters through the jugular foramen. In this diagram, the dura has been removed. Now we can see a transverse crest which divides the superior vestibular nerve lies above the transverse crest, and inferior vestibular nerve and cochlear nerve lies below the transverse crest. This is an enlarged view. Here we can see the transverse crest. Above is the superior vestibular nerve and facial nerve. The facial nerve lies anterior to the superior vestibular nerve, and below the transverse crest is the inferior vestibular nerve and cochlear nerve, and the cochlear nerve lies anterior to the inferior vestibular nerve. Here again, a cleavage plane is created, so we can clearly appreciate the nerve bundles. This is above is the superior vestibular nerve. Anterior to the superior vestibular nerve lies the facial nerve. Below is the inferior vestibular nerve, and anterior to inferior vestibular nerve lies the cochlear nerve. In this diagram, we can see the superior canal along with the posterior canal that communicates with the common crus. Inferior-lateral to the canal lies the endolymphatic duct and the endolymphatic sac. This is another diagram that is an enlarged view. Superior canal along with common crus goes into posterior canal. The endolymphatic duct and endolymphatic sac lies inferior-lateral to internal acoustic meatus. This is the jugular bulb. We can see the jugular bulb. In the next diagram, again, we can see this is the transverse crest that divides the superior vestibular area above and the inferior vestibular area below. And also this is the vertical crest that divides the facial canal anteriorly and the superior vestibular area posteriorly. Another diagram showing in this diagram, the right internal acoustic meatus is viewed, and the posterior lip of internal acoustic meatus has been removed. We can see this is the transverse crest. Above is the superior vestibular nerve. Anterior to that is the facial nerve. Below is the inferior vestibular nerve, and anteriorly is the cochlear nerve. Now we will see the anterior-lateral view of right cerebellopontine angle. This is the anterior-lateral view. First, we will discuss the neural relationships. So this is the 7th and 8th, that is the facial and vestibulocochlear nerves that lies lateral to the pontomedullary sulcus. This is the pontomedullary sulcus, pons, medulla. This is the pontomedullary sulcus. This is the lateral part, and here arises the here is the junction of 7th and 8th nerve with the brain stem. Now, the 7th and 8th nerve lies anterior superior to the choroid plexus, anterior superior to choroid plexus, and anterior to the flocculus. This is the flocculus, this is the choroid plexus. And this is the olive. So the rostral pole of olive. So 7th and 8th nerve lies slightly posterior to rostral pole of olive, anterior superior to choroid plexus, anterior to flocculus, and in the lateral end of the ponto medullary sulcus. This is another fissure, that is the cerebellopontine fissure that we have discussed previously. This is the superior limb of cerebellopontine fissure. This is the inferior limb of cerebellopontine fissure. The superior limb of cerebellopontine fissure goes above the trigeminal nerve. This is the trigeminal nerve. And the inferior limb goes below the foramen of Luschka. This is the foramen of Luschka. And from below comes the cerebellomedullary fissure. This is the cerebellum, this is the medulla, the cerebellomedullary fissure that extends superiorly, and it communicates with the inferior limb of cerebellopontine fissure. It communicates with the inferior limb of cerebellopontine fissure at the foramen of Luschka. This is the ninth, that is the glossopharyngeal, vagus, and accessory nerve. This is the hypoglossal nerve. Now, arterial relationships. The first is the superior cerebellar artery, which is a branch of basilar artery. It lies above the trigeminal nerve. The second is anterior inferior cerebellar artery, branch of basilar artery. It comes down below the facial and vestibular nerve. These are the facial and vestibulocochlear nerves. It divides into two trunks. This is the rostral trunk. This is the caudal trunk. The rostral trunk goes above the flocculus. This is the flocculus. The rostral trunk goes above the flocculus, and it supplies the middle cerebellar peduncle. This part is the middle cerebellar peduncle. In this diagram, we can appreciate this is the middle cerebellar peduncle. So the rostral trunk supplies the middle cerebellar peduncle, and the caudal trunk lies below the flocculus. The third branch is the posterior inferior cerebellar artery that arises from the vertebral artery. Initially, it goes between the rootlets of hypoglossal nerve. These are the rootlets of hypoglossal nerve, and further, then it goes between the vagus and accessory nerve rootlets to go onto the cerebellum, and it supplies the cerebellum and gives hemispheric branches. Venous relationships. The important veins that converge at the junction of facial and vestibulocochlear nerves with the brain stem are the lateral medullary vein. This is the lateral medullary vein. This is the retroolivary vein. This one is vein of Ponto medullary sulcus. This is the vein of cerebellopontine fissure that is formed by the anterior hemispheric vein. The anterior hemispheric vein goes on anteriorly to form the vein of cerebellopontine fissure. And this is the transverse pontine vein. The three veins that are the transverse pontine vein, the vein of middle cerebellar peduncle, and vein of cerebellopontine fissure goes on to form the superior petrosal vein, which then continues into the superior petrosal sinus. Now we will be discussing the relationship of foramen of Luschka and lateral recess of fourth ventricle to the junction of facial and vestibulocochlear nerve with brain stem through a suboccipital approach. This is the inset. The straight line is the incision. The dotted line is the craniotomy. So in this diagram, we can see the pyramid of vermis, the cerebellar tonsils, the biventral lobule. This part is the tila choroidea, and the foramen of Magendie is present. Laterally, we can see the foramen. The important structures are foramen of Luschka, through which the choroid plexus protrudes, and above the foramen of above the choroid plexus is flocculus. So this is the junction of 7th and 8th cranial nerve with the brain stem, and it lies uh, anterior superiorly to the choroid plexus and anterior to the flocculus. This is the 9th, 10th, and 11th cranial nerve that enters through the jugular foramen. This is the hypoglossal nerve that enters through the hypoglossal canal, and it lies ventral to the olive. In this diagram, the right cerebellar tonsil has been removed, and the cerebellum here has been retracted. This is the peduncle of cerebellar tonsil. Uh, this part is the inferior medullary velum. It goes on laterally to form the peduncle of flocculus, and the lateral part, the inferior medullary velum, stretches till the flocculus. Flocculus lies laterally. In this diagram, the tila choroidea has been removed, and we can see the choroid plexus. Now we will be discussing the Ntu Superior View. Again, in this view, the cerebrum and tentorial cerebelli has been removed, as we have discussed previously, that this is the cerebello-pontine fissure. Cerebello-pontine fissure has superior limb and an inferior limb. This is the superior limb of cerebello-pontine fissure, and this is the inferior limb of cerebello-pontine fissure. This is the facial and vestibulocochlear nerve. This is the junction of facial and vestibulocochlear nerve with the brain stem. The superior limb goes above the trigeminal nerve. The inferior limb of the cerebello-pontine fissure goes below the foramen of Luschka. Arterial relationships. Again, this is a superior cerebellar artery that lies above the trigeminal nerve. Anterior inferior cerebellar artery, as I have told previously, that it divides into a rostral and caudal trunk. The rostral trunk goes below the 7th and 8th cranial nerves. It then goes, this is the flocculus, it goes above the flocculus to supply on the middle cerebellar peduncle, and the caudal trunk goes below the flocculus to supply on the cerebellum. This one is the posterior inferior cerebellar artery. It goes between, initially it goes between the hypoglossal nerve, and further it goes between the glossopharyngeal and vagus nerves. These are the venous relationships. The important arteries are the vein of cerebello-pontine fissure. This is the vein of cerebello-pontine fissure, vein of cerebello-medullary fissure, and this one is the vein of middle cerebellar peduncle. So these joins and goes on to the superior petrosal vein, and it further goes to drain in the superior petrosal sinus. Now, we will see the posterior view through a retrosigmoid craniotomy approach. And the neural relationships are again, this is the 7th, the facial and the vestibulocochlear nerve, and enters through the internal acoustic canal. This is the junction of 7th and 8th nerve with the brain stem. It lies anterior to the flocculus and anterior superior to the choroid plexus. Flocculus, and this is the choroid plexus. This one again, above is the cerebello-pontine fissures, superior limb. Below is the cerebello-pontine fissures, inferior limb. This is the Ponto medullary sulcus, as we have studied previously, that the 7th and 8th nerve junction of 7 and 8 nerve with brainstem lies in the lateral part of the Ponto medullary sulcus. The 9th, 10th, and 11th cranial nerve enters through the jugular foramen and 12th through the hypoglossal canal. Arterial relationships, again in this view, this is the superior cerebellar artery above the trigeminal nerve. This is the anterior inferior cerebellar artery that again divides into rostral and caudal trunk. The rostral trunk lies above the flocculus and it goes to supply the middle cerebellar peduncle. The posterior inferior cerebellar artery, it lies initially goes between the hypoglossal rootlets and then between the vagus and vagus and accessory nerve, that are the 10th and 11th cranial nerve. This is the pica. Venous relationships, again, as we have discussed previously, in this view, important vessels are vein of cerebellopontine fissure. This is the vein of cerebellopontine fissure. Vein of middle cerebellar peduncle. This is the vein of middle cerebellar peduncle. And another important vein is the vein of cerebellomedullary fissure. This one is the vein of cerebellomedullary fissure. This is vein of Ponto medullary sulcus. And this one is the transverse pontine vein. So the transverse pontine vein of middle cerebellar peduncle and vein of cerebellopontine fissure goes on and it forms the superior petrosal vein, which further drains into the superior petrosal sinus. Thank you.
Thank you, Dr. Daniyal, for such a detailed illustration. Now I would like Dr. Hassan to please share his views and maybe share a few cases if you have. Dr. Daniyal, can you please stop sharing?
Yes, sir.
Dr. Hassan, if can you hear us?
Can you hear me, Dr. Saad?
Yes, Dr. Hassan, I can hear you. If you have a presentation to share, please share.
Yeah, I have. I am starting it. First of all, thank you very much for inviting me, and it was a very nice talk by Dr. Daniyal. This is a very big topic.
Are you sharing your presentation, Dr. Hassan?
Yeah, I'm trying. Can you see it?
Not yet. Yes, it's sharing now. Yes, we can see your presentation, Dr. Hassan.
So I will be touching just few clinical applications of this topic, and then showing you few cases. As already described, 3 complexes of the CP angle. These are very important because all these 3 have their own part of the cerebellum, peduncle, tentorial surface, and arteries, and all cranial nerves. So upper complex has superior cerebellar artery, very important for the surgeries for trigeminal neuralgias, and also midbrain. So I'm not going into the detail because it has already been discussed. So for craniotomy, superior approach for the upper complex like MVD for trigeminal neuralgia, central approach for the vestibular schwannomas, or tumors like meningiomas, and inferior approach for the lower cranial nerves. So the few points about the anatomy of the CP angle. The cranial 7 usually exits in the lateral part of the pontomedullary sulcus, about 2 mm anterior to the entry zone of the cranial nerve 8.
Dr. Hassan, your slides aren't moving, I guess. We're still on the slide that shows your name, if you haven't changed yet.
I am on the 3rd slide.
Yeah, now it's changing. Now it is changing.
Okay, can you see this one now? The keyhole
Yes, we can,
craniotomy.
yes, we can see that one.
So this is the basically keyhole craniotomy. While for upper one for superior approach for the trigeminal neuralgias like MVT, and the central approach for the tumors of the vestibule schwannoma, and inferior approach for lower cranial nerves. So as far as the anatomy, the few points, the cranial nerve 7 is anterior to the lateral part of the anterior to the cranial nerve 8. While the 5 cranial nerves, as already discussed, pass through the internal auditory canal, like facial nerve, superior and inferior vestibular nerve, and the cochlear nerve, and the nervus intermedius, which later joins the 7th cranial nerve. It's 7 up and cock down. 7 is up and cochlear is below that. This is the view which shows the 7th cranial nerve, and up and low are the. This is the 7th cranial nerve, and this is the superior and inferior vestibular nerve.
I'm sorry, but you're on the same slide which shows keyhole craniotomy.
Can you
Now,
see it now?
We are on the slide that shows like lateral triangle of the posterior fossa.
Okay. So the cisternal segment of the cranial nerves in the lateral posterior fossa form 4 visual triangles. This is very important concept. These triangles are basically, can you see now these triangles?
We are on the text, not yet the picture. If you can maybe show the picture, I think, which is the next slide. Yeah, now we can see this. Yeah, now we can see the picture.
I think when I maximize it, it just doesn't go to the next slide. So I'll show it in this view. So the 4 corridors are the triangles, are the superior triangle. And in the center, there are 2, central superior triangle and central inferior triangle. While in there is an inferior triangle. Those CP angle forms combination of central superior triangle and central inferior triangle. So for practical purposes, it is the space between cranial nerve 5 and the lower end of the cranial nerve 10. So this is the part of the CP angle. So this tumors which are usually formed or other pathologies in the CP angle arises from their own things that, like in cisterns, there are formation of epidermoid cysts, dermoid cysts, the arteries, we can have aneurysmal ectasia, skull-based tumors like cholesterol granulomas, chordromas, chondromas, and in meninges, we have meningiomas, arachnoid cysts, and other metastases, and nerves 5th to 12th can have all, we can have all schwannomas from every nerve, and cerebellar ventricle, we can have glioma, the pandemomas, the meningioblastomas, obviously the commonest primary intraaxial tumor, medulloblastomas. So this is for residents for exam purposes. Vestibular schwannomas account for 90% of the lesions, and followed by meningiomas, epidermoid cysts, aneurysm, arachnoid cysts, few cases of metastasis as well. All and other diagnoses about 2%. So this is all the repetition of the previous slide. So CP angle surgery. Now I come to the clinical aspect of this anatomy. CP angle surgery was first successfully done by Charles Balance in 1894, and the tumors was removed with finger. In 1917, Harvey Cushing first advocated the removal of the intracapsular removal of the tumor. In 1925, Walter Dandy was the first to give the concept of total tumor removal. And then in 1967, first preservation of the facial nerve was done. Then later, after the introduction of gamma knife, it was in 1980 that there was an era which goes for the start of stereotactic radiosurgery for smaller kind of lesions. So the commonest acoustic schwannomas about 8% of all the intracranial tumors, they arise from the vestibular component of the 8 cranial nerve near the auditory meatus. So there is a classification which is popular as Sami and co-worker with 1995, which shows different kind of tumor according to the extensions. Like the first is purely intrameatal tumor that doesn't peep into the CP angle, and then there is the intra and extrameatal T2. It starts peeping into the CP angle, and then there is the tumor which reaches to the brainstem, and then the compression of the brainstem, and then a tumor which causes the compression and displacement of the fourth ventricle leading to the hydrocephalus. So this is one of the case in which there is a small CP angle vestibular schwannoma, in which we have performed right suboccipital craniotomy and removal of the tumor, and this was the post-op scan of the patient after the removal of the tumor. The case which is we have brought here is the a young female with the meningioma. This is whereas meningiomas are the second most commonest tumors which arise from the capsule near the crinoid villi. The patient usually presents with all the posterior fossa like symptoms like ataxia, nystagmus, facial hypoesthesia, but usually you don't present with the hearing abnormalities to start with. So this is a case in which there is a large CP angle meningioma. You can say the petrous meningioma. So these are few intraoperative images. This is the image after the removal of the tumor. You can see the surface of the cerebellum. Overlying vessels are intact along with arachnoid. So this is the lady after the surgery. So a few interesting pathologies in this CP angle. Like this is a case of epidermoid. To differentiate epidermoid from the arachnoid cyst, we usually go for the diffusion weighted images, and it is a very important concept for exam purposes as well. So this is a case of fifth cranial nerve schwannoma. It's also very common. After 8, there is the most commonest is the fifth cranial nerve schwannoma. We have a case of glomus jugulare, which we sent for the radiosurgery later on. And this is a very rare case of cranial nerve 7th schwannoma. And we have a very rare case of cranial nerve 10th schwannoma as well. So after the start of radiosurgery, now the patients are getting some referral to the radiosurgery, but this is a case in which the gamma knife was done. And after 6 months, you can appreciate a slight decrease in the size of the tumor, and 9 years, again, the tumor is still present. So I must say the gold standard for the treatment of these kinds of lesions is still surgery. So I thank you very much to all of, I thank all of you. If you have any question.
Thank you, Dr. Hassan, for your cases and your expert opinion. If there are any questions, please use the chat box. This is the time to ask any questions. Dr. Hassan, thank you for your presentation.
Thank you.
Thank you for sharing your cases. I urge the trainees to get involved and ask questions because this is the time if you have any queries. If not, then we will conclude this session. So I don't think they have any question, Dr. Hassan. I think you've explained it. You've explained it way too well, and I thank you for your presence. And I would like to have you in the future as well.
Thank you very much. Thank you.
And next week we will be doing posterior fossa cisterns, and so Dr. Pravat has asked about relationship of superior cerebellar artery with the 7th cranial nerve. So basically, superior cerebellar artery relationship is basically related with the trigeminal nerve. Dr. Pravat. It's not. It's basically ICA that is related to the seventh cranial nerve, basically which Dr. Daniyal showed that it divides into rostral and caudal loops, which the rostral loops goes above the flocculus while the caudal loop goes below the flocculus. So yeah, Dr. Yasser Khyber is asking what kind of fibers are carried by nervous intermediates, and that question is for Dr. Daniyal. Dr. Daniyal, are you still with us? Okay.
Yes, sir.
So what kind of fibers are carried by nervous intermediates?
Parasympathetic fibers for submandibular and sublingual glands.
Okay. So I hope Dr. Daniyal that answers your question. Dr. Pravat actually wanted to ask. I mean, I'm sorry, it was my mistake. He meant he wanted to know the relation of semicircular canal with the seventh cranial nerve. So, Dr. Daniyal, can you answer this question if you may, or maybe Dr. Hassan can fill in? What is the relationship of the semicircular canal with the seventh cranial nerve? Dr. Daniyal is probably showing the picture where he showed the bony anatomy with the.
Sir, can you see this image?
Dr. Hassan, can you please? Yes, we can see the image. Yeah.
Okay, so in this diagram, this is the internal acoustic meatus. This is the seventh nerve, and this is the eighth nerve. This is the inferior lateral, the endolymph duct and endolymph sac lies inferior lateral to the inferior acoustic meatus.
Can you use a pointer, please? Maybe maybe use an arrow.
This is the internal acoustic meatus.
Can't see your arrow, Hassan. Daniyal, I can't see your arrow. We could see it previously, but not right now.
Sir, can you see this?
No, I cannot. So okay, keep explaining if you can.
Sir, the seventh nerve, that is the facial nerve, and the eighth, that is the vestibulocochlear nerve. It enters through the internal acoustic meatus. So this is the internal acoustic meatus. Inferior lateral to the internal acoustic meatus lies the endolymph duct and endolymph sac. It lies inferior lateral to the internal acoustic meatus, which carries the seventh and eighth nerve.
And what's its relationship with the semicircular canal? Superior semicircular.
It lies inferior to the. It lies inferior to the superior semicircular canal.
So, Dr. Hassan, are you still with us? I think Dr. Hassan, can you unmute yourself, please? Can you make Dr. Hassan co-host? I think he went offline and came back again. So the question is, how often do you take the petrosal vein? I think if that's the question. I think he has issues with. So if by Danny if you're talking about the superior petrosal vein, you can sacrifice the superior petrosal vein without any issues. But you know, it is said that if you can spare it, then you should spare it. But you know, usually when you retract too much, you have to be careful because once it ruptures, it can be a handful. If there are any other questions from the participants, we like to have them now, or otherwise we'll conclude this session. And next week we'll be doing posterior fossa cisterns. I don't think there's any more questions, guys. Thank you for your participation. I urge you to participate, and we'll see you all next week, same time, and we'll be doing posterior fossa cisterns. Thank you, Dr. Daniyal, for the presentation.
Thank you, sir.